involved in our specimen collection, fixation, grossing, processing, embedding, sectioning, staining, and microscopy, as the flowchart says. The errors which we are going to discuss today have been divided into three parts based on the stage at they occur. They are pre-analytical errors, analytical errors, and post-analytical errors. This classification may differ from the classification used by pathologists. This is anyways a lab classification. Here the main focus is our histopathology lab. So here pre-analytical errors are those errors, all those errors which occur before the sample reaches our lab. And analytical errors are all those errors which occur inside our histopathology lab from grossing to staining. And post-analytical errors, as the name suggests, they are all those errors which occur after we finish our main work in lab. That is reporting errors, typing errors, report interpretation errors. Now, let's begin with pre-analytical errors. Pre-analytical errors, as I have already said, they are those errors which occur before we start our tissue processing in laboratory. They are improper tissue collection, delayed fixation, wrong fixative use, inadequate labeling or misidentification, insufficient sample size, wrong container, specimen without form. There are many other errors, but the time is limited, so I will elaborate all these one by one. By improper tissue collection, we here mean that if the person who collects the sample misses the main lesion or collects from the wrong site or uses the wrong method for the collection. In that way, the tissue gets damaged if they use wrong ways of collection, and we may lose important morphological details of the tissue. Delaying fixation. By delaying fixation, we here understand that sometimes when they collect the sample, but they do not put immediately it into the fixative. The fixative is formalin, but they delay it, and in this delay, we lose important details of our tissue. Wrong fixative use. Sometimes they actually use any fixative, but the fixative is not appropriate. They sometimes send us in alcohol. As you can see here in the slide, there is a bottle, a DNS bottle. Though DNS is a good fluid, but it's not a fixative. Here the autolysis and putrefaction starts immediately because DNS is also a good place for microbes to grow. So putrefaction is definitely going to attack. Inadequate labeling or misidentification. Since when they collect a sample, they do not collect a single sample a day. They collect multiple samples. There are the chances of mislabeling and misidentification in their part as well. Insufficient sample size. By insufficient sample size, we understand that sometimes they send us very minute biopsies, which we eventually lose in processing. Those biopsies are especially from endoscopic biopsies, true cut biopsies, and core biopsies. Wrong container. As I already said, sometimes they send us in a wrong container. Before understanding the wrong container, we need to understand what a good container for histopathology is. For histopathology, a good container is the container which has two main basic properties: a wide mouth and a lid to close. If a container lacks these two properties, the container is wrong. Because in histopathology, especially in grossing, we require opening and closing of sample, and for fixation we need to put formalin. For that we need a wide mouth, and for the formalin to stay inside without fumes, we need the lid. Space especially suffers as we have to send back the patient to the person who collected it. In meantime, the patient actually gets delayed. Here I have given the form which we actually require in histopathology. This form has columns for all the basic details from name to MRD and relevant clinical data for history, post and intraoperative findings, and radiological data. This is what our pathologists require during reporting. So the troubleshooting. You need to ensure proper collection of proper size and from proper site. Both are important, size and site. Ensure proper labeling protocols. Use correct fixative, that is 10% formalin. Immediate fixation after collection. Use container with lid of proper size. And write all important details on form. Now, let's begin with analytical errors. These errors occur during tissue processing and examination in the lab. They are improper fixation, grossing errors, poor tissue processing, wrong embedding, sectioning artifacts, and staining errors. Fixation errors. Since fixation actually prevents autolysis putrefaction and saves the morphology of tissue, if this tissue is underfixed, it will be poorly preserved. And the basic cause for this is low formalin concentration. You need to actually maintain the 1:20 ratio or at least 1:10 ratio of tissue is to formalin. Poor fixation. If you poorly fix the tissue becomes hard and it also doesn't take the stain, especially immunohistochemistry stains where you need open antigens and you need retrieval. The retrieval time actually increases because majority of antigens are masked. Incomplete penetration of fixation. This actually happens with large specimens like gynecological specimens where the specimen is big and the fluid does not penetrate, the fixed tissue does not penetrate and deep enough to fix it well. So you need to cut slices of the tissue to allow penetration. So it is sometimes difficult to actually do everything correctly, and sometimes the labeling gets disturbed and they mislabel 1 or 2 samples, and after they need to actually correct the labeling. Inadequate fixation. You need to make sure that the sample is already well fixed before grossing. Incomplete sampling of lesion margins. You need to completely sample the margins of tissue to allow better reporting. Tissue damage due to rough handling. You do not need to be rough with the tissue, as rough handling may damage the tissue. Wrong cassette selection or overloading. As we have color-coded cassettes in our labs, so you need to be sure which color to use for which tissue. And also you need to be sure to not overfill the tissue, especially in resected prostate. We sometimes find a tissue which is actually very, very overloaded cassette. Sometimes if the cassette opens in the processing, we may lose all the tissue pieces. Overly sized tissue sections. Sometimes you cut the cross sections which are overly sized. They do not completely fit the cassette and they actually break during the cutting. Wounds sent to processing without decalcification. Sometimes they actually send the wounds to processing without decalcification. And as you can see here, I have a cassette without label. Sometimes they actually forget to label. Troubleshooting. You need to verify patient details and specimen labeling before grossing. Ensure proper fixation, 10% neutral truffle formalin, adequate volume. Follow standard grossing protocols for each specimen. Orient and each margins so that the reporting pathologist will be able to find the positive and negative margins. Take representative and adequate sections. Maintain proper documentation and photography. Make sure every bony tissue piece is sent for decalcification before processing. Now, sometimes when they forget to send for decalcification, this is how we decalcify the tissue later on. This is how we deal with it. First of all, we do not come to know immediately that the wound is not decalcified. At the later stage, especially in cutting, when we try to actually cut the wound, it breaks the blade, but wound does not cut. So our first hand mechanism for this is surface decalcification. We take the block, we trim it, and then we put it in surface decalcification in a weak acid like formic acid or a low concentration HNO3 for few minutes so that the superficial calcium gets removed and the tissue becomes soft enough to take a section. This stands true for low sized biopsies or small sized biopsies where the calcifications are very low. If the calcification is very high, especially a full bony tissue piece, you may not require to do surface decalcification. A surface decalcification fails to decalcify it. For this, there is another process, re-decalcification, reprocessing. In this, we actually deparaffinize the block first by using xylene and then put it in alcohol for hydration. After hydrating it, we put it in decalcifying fluid and then reprocess it, and after that we can easily cut it. There is another method that's called EDTA method, water, because the area has not been fully dehydrated. And meanwhile, if you check our machine, the alcohol quality is actually very low it has gone below the red mark. You always need to make sure that the alcohol quality stays above red mark. Solution for this is, as I have already said, replace alcohol regularly and increase dehydration time. Now, poor paraffin infiltration. The problem here comes is we get brittle tissues where holes are seen. If you can see here, I may not be able to zoom in. There are white spots in the tissue. They are not actually white spots, they are the holes which make tissue more brittle. The cause for this is low paraffin temperature. When the temperature of paraffin is low, the penetration actually is also low. Inadequate clearing. So, the clearing. What does the clearing do? Clearing makes sure that the wax gets the environment to actually penetrate the tissue. As wax is not miscible with alcohol, so clearing removes alcohol, the xylene removes alcohol. You need to remove alcohol completely to allow proper paraffin infiltration. So here the solution is simple: maintain 58 to 60 degree paraffin temperature, ensure proper clearing. Tissue overhardening. In tissue overhardening, the tissues become difficult to cut. As you can see, it was not possible for me to actually cut this section. So I have taken the picture of it. The cause of this is overexposure to xylene or alcohol. Both xylene and alcohol make tissues overly hardened. Or the high temperature. The temperature is important because high temperatures actually increase the penetration time. Actually increase the penetration and decrease the penetration time. So if the reagents have penetrated well enough in less time, then normal time may be abnormal for the tissue. So you need to reduce processing time overall. As both alcohol and xylene are here, you need to reduce both overall processing time and monitor temperature regularly. Now the reagent contamination. Here the problem is ineffective processing. Causes are carryover between solutions, dirty containers, bad quality reagent. You need to change reagent regularly and clean the equipment. If you see, these are two tanks, wax tanks, which actually became dirty only after consuming bad quality reagent. So you always replace bad quality reagent with good reagents. And with this, my part of presentation ends. Now I would like to invite my colleague Ramesh, who will continue this presentation.
A very good morning to all of you. As Fayaz already discussed some of the errors that we face in histopathology, as he discussed some pre-analytical as well as analytical errors. In analytical errors, I will start from embedding. The most common embedding errors are incorrect tissue orientation. When the desired orientation is not facing the cutting plane or block, for example, if we will take example of the neck of gallbladder, the lumen of are not good or ideal. The next is overheating of paraffin wax. As we are in embedding, we are using paraffin wax. The melting temperature of paraffin wax is about 58 to 60 degrees. That means if the temperature exceeds above 50 to 60 degrees, for example by 10 degrees, then it is overheating. What does this overheating cause? It causes irregular shape of the block and causes cracking in blocks. During cooling and affects the quality of sections and during section taking in microtubing. The next problem is air bubble formation. As Fayaz already discussed in the previous slide, that when the temperature of the wax or the temperature of wax is below its melting temperature, there is possibility of formation of air bubbles. When the temperature of paraffin wax is below its melting temperature, the air bubbles get formed in blocks, causing problems to visibility of tissues. For example, as we know, the specimen we receive, they are liquid biopsies where the size of tissue core is much smaller. Endoscopic guided biopsies, the tissue bits are much smaller. CT guided biopsies, the tissue size is very, very tiny. And USG guided biopsies. Impurity and quality of the wax also interferes with such type of biopsies during microtomy. The other problem we face is tissue not fully embedded. The problem occurs when the size of tissue is larger than the selected mold. The tissue is outside of the block and causes the inappropriate section cutting and quality of reporting. When the desired tissue is not fully embedded, when the desired tissue is not fully seen in microscope, the pathologist feels and needs the deep cuts and it delays the reporting time. The next challenge we face in embedding is cross-contamination between specimens. As you can see in the image, this is an image. Multiple plastic tissue cases are open at a time, and these are few blocks. One block that is folded or that is set in block holder. You can see the tissue that has been embedded at one side of the block, and it is not an ideal position of a tissue to be embedded. And you can see this here, there is a crack. There is a crack present here. As I told you that the possibility of cracking is when the block is cooled rapidly after formation of the block. So when multiple plastic tissue cassettes are opened during embedding, there is always possibility of cross-contamination of specimen. The next is improper mold selection. Improper molds, it causes not only wastage of time and reagents, but also affects the section cutting and staining quality. The next one is improper labeling. As I said here, in this image you can see multiple tissue cassettes has been opened at a time. When a technician casts the blocks at a time, by any reason he forgets which tissue from which cassette he has embedded in which mold. There is a possibility of he may take one label from one section, one cassette, and will label it to another block. How to troubleshoot these problems? Ensure correct tissue orientation. As I said, all those tissues which have the lumen present, the pathologist always needs a cross section of that lumen, so that all these layers from outside to inside, for example from mucosa, submucosa, musculus, all the cell layers are visible in stain or in microscopy. Maintain paraffin temperature, that is 55 to 60 degrees. Remove air bubbles before solidification of the block. Use appropriate mold size for tissue. Clear forceps between specimen. Clean forceps between specimen. This is a very important point here I will mention, and I will again mention it, that when we are making the blocks of tissue where the size is very small, like USG guided biopsies, tricot biopsies, USG guided biopsies, or CT guided biopsies, the size of tissue is very small. Maybe a bit of tissue gets adhered at the bottom of the forceps, then there is a possibility of cross contamination. Allow proper cooling before sectioning. If rapid cooling occurs, there is a possibility of cracking in the block, which may interfere the section taking. And match labels with forms. For example, when a technician has completed embedding, at the last he must check and recheck it that how many cassettes have been put by a pathologist during grassing. are they equal, are they less, are they exceeding the, as mentioned on the form. This should be ensured. Now, the other step, as we discussed in histopathology, is section cutting or microtomy. The errors we face here is charting effect, that is also known as mentioned blind effect. Also known as mentioned blind effect, mostly it is caused by hardness of tissue, the tissue which has usually calcification. For example, when we receive a sample as MLC sample, most of the times we have seen that the arteries are many other times blocked. There is a calcification present that will cause this problem. Dull blade or fast cutting speed during microtomy. Compression of sections. You can see here, this is an image that shows charting. That here you can see the high density of tissue and low density of tissue, high density of tissue, low density of tissue or cellularity. You can see this looks like some field where, I don't know. Compression, the other error we face is compression of sections. These are usually caused by improper clearance angle. It should be between 3 to 8 degrees or because of dull blade. And it affects the microtomy as and hence reporting. The other thing we face is wrinkles or folds in sections. These are caused by improper tissue flotation bath temperature. For example, as I said, that the wax we are using, the melting temperature, it has 58 to 60 degrees. When this temperature, the seed is much below the melting temperature, then there is a possibility of getting folds in the section. The other problem we face is tearing of sections. The most commonly caused is overhardening of tissue or defective blades. Other problem is knife marks or score lines. They are usually caused by dirt particles present on front side of the blade or hard tissue or tip of the forceps while taking the section. You can see here, this is an image. You can see a fold here. This has happened because of low temperature in tissue flotation bath. How to troubleshoot these problems which we are facing in microtomy? For charting, use fresh blade, slow speed of sectioning and soften the block by increasing its temperature. If the block is hard because of cooling, if block is hard because of calcification, then Fayaz already had said we had to go for iridicalcification. He already mentioned it. For compression is adjust clearance angle and replace blade. The clearance angle must be between 3 to 8 degrees. For wrinkles and folds, optimize the tissue flotation bath temperature. Adjust 3 to 5 degrees below melting temperature of wax we use. For tearing, irradiate or soften the tissue, ensure proper processing. For knife marks or score lines, it is better to change the blade for better section and quality staining. For uneven sectioning, all the components of microtome needs to be tightened and block holder must be tight and fully clamped. After microtomy or section cutting, the next step in histopathology is staining. As in histopathology, the routinely based stain we use is hematoxin and eosin. The common errors are uneven staining. Some parts are stained and the other are not well, so causing uneven staining. This is usually caused by incomplete deparaffinization, as most of the consultants ask this us during the winter times. One is poor nuclear staining. It is usually caused by improper differentiation or weak hematoxin. Recently we have faced this problem and it took, I think, 3 to 4 days to troubleshoot this problem. Precipitate formation. Usually precipitate should not form, but as stain gets older and older and unfiltered, the precipitate get formed and causing problems like patches of high concentration stain in staining. The next one is fading of staining. Improper mounting and long exposure to light causing fading of stain. You can see the image here. This is because of the retention of wax here. We cannot see a clear image in this section. Now the troubleshooting in this problem is, for proper deparaffinization, use fresh xylene, adequate timing and temperature usually during winter times. As I said, the temperature here in Jammu is below 15 degrees Celsius. So for this, we are using a trough containing xylene put in incubator at around 45 to 50 degrees Celsius. Then the deparaffinization is happening there. Standardize staining time and follow the protocols strictly. For example, after troubleshooting any error, we have to follow the protocol then on a regularly basis. Filter and replace reagents regularly. Always check pH and quality of stains. Control the differentiation step carefully, as mostly poor nuclear differentiation is occurring because of this step. Maintain equipment and clean glassware for storage and proper balancing of reagents during weighing, measuring of the reagents. As I have seen multiple times here in Jammu, many of the technicians, they are using hand like this. This way this much and this way this much. But this is not a scientific way. We must avoid it to ensure proper staining. Mounting. After the staining is complete, now the last step is mounting. Common errors that occurs during mounting are air bubble formation, improper cover slip placement, and excessive use of mounting medium. As you can see here in this image, it is not clear. You can see the cover slip is slipping towards the right, and here also, and it's not a right way. Solutions for these common errors are: keep the stainer slide in xylene and apply cover slip properly. Use appropriate mounting medium and avoid dust contamination and excessive mounting medium. The next part of this is post-analytical errors, as we are not much dealing with this, but still I will say some I will say a few words about this, like misinterpretation of the slides, reporting mistakes, data entry errors. These usually happen here, and for their troubleshooting, we have to double check the reports as well as use digital systems where the possibility of occurring these errors is very less. Peer review of difficult cases. I very thank you.